Now, ovarian torsion is an area which is fraught with pitfalls. That would require a whole separate topic for a lecture, but I just want to highlight a point that when we do Doppler with ovarian torsion, we should not rely solely on the Doppler for the diagnosis of torsion. Why? Because absent ovarian blood flow does not mean ovarian torsion. We may see absent flow even in a normal ovary. This could be because of technical reasons. This could be because of physiologic reasons that the ovary is resting in that part of the menstrual cycle. And now the opposite of that is presence of blood flow in an ovary does not exclude torsion. You can have an ovary that's undergoing torsion, and often we do see arterial or venous blood flow. And that's actually good because that means that that ovary is probably salvageable. It does improve our ovarian salvage rate because there is still blood flow supplying that ovary. So we should trust the 2D picture more than we trust the Doppler as far as ovarian torsion. We can look for 2D signs, mainly an enlarged, swollen, edematous ovary. Many times the follicles are pushed towards the periphery of the ovary. Sometimes there is an ovarian mass that causes the twist. So the 2D impression is very important. Blood flow, seeing arterial or venous blood flow within a swollen ovary with peripheral follicles is a good thing. We should not discount the fact that this could be torsion because this is a salvageable or hopefully will be a salvageable kind of ovary, which it was in this case. They were able to untwist the ovary, and this 23-year-old woman did not lose her ovary. I want to make a couple comments on Ring of Fire because that's another big pitfall. Ring of Fire was first described with ectopic pregnancy and has sort of stuck in our minds as a sign of ectopic pregnancy. Well, yes, it could be a sign of ectopic pregnancy, but much more commonly it is a sign of a corpus luteum. The corpus luteum cyst is much more likely to have a ring of fire, and it is much, much more common than the ectopic pregnancy. Here they look identical. Either one could be an ectopic or either one could be a corpus luteum. And that ring of fire statistically is more likely to be related to a corpus luteum than to an ectopic pregnancy. So once again, we should not rely on the ring of fire. We use the 2D, not the Doppler, to differentiate the ectopic from a corpus luteum. The ectopic is separate from the ovary. The corpus luteum is part of the ovary. So that's an important point. And last but not least, when you've gone through all these steps carefully, trying to avoid these pitfalls, and if you're not coming up with an explanation for the patient's gynecologic complaints, think of some things outside of GYN conditions. Think of urinary tract problems like renal calculi, in which case you'd go looking for a renal calculus. This is a convert here to a transvaginal. There is an echogenic focus here, which could be a little, we're suspecting a ureterovesical junction stone. Here we put on our color. The twinkle confirms that that's a stone, and the jet shows us that there is urine flowing past the stone, but it's spraying out into the bladder. It doesn't have that nice little jet because this is serving as a partial obstruction. So we would do the full evaluation. Here's another example. A stone in the distal ureter, beautifully documented by transvaginal sonography. Turn crosswise, there's the echogenic focus with the acoustic shadow. And think of not just GU system, think of GI conditions, appendicitis, inflammatory bowel diseases, abscesses, colon cancer, fistulae. You can pick those up transvaginally. Here's appendicitis. This is a pelvic appendix that caused gynecologic symptoms. And it has, we look for that gut signature. We look for a blind ending tubular structure with layers and appendicolith if we're lucky. Here crosswise we can see multiple rings, hypercoic, hypo, hyper, hypo, hyper. This is gut signature. Turn longitudinally, blind ending tubular structure, tender, painful, next to the ovary, irritates the ovary, presents as pelvic pain, not as right lower quadrant pain. Another case here where we suspect something else going on because we can't make a gynecologic diagnosis, and in this case a mass. We look more carefully, we realize there's a calcification, that's the appendicolith, and there's a rupture, and there's now an abscess, ruptured appendix with an early abscess in the pelvis. So we think outside of gynecologic conditions. So in review then, how do we avoid pitfalls in transvaginal sonography? We go systematically. We get a good history. We pre-scan transabdominally. We make sure we understand how the beam's coming out of the transducer and how our image is projected onto the screen. We check our technique. We check for depth, gain, focus. We will then look at the bladder, the cervix, then check the uterus, look around in the adnexa, know our blind spots, make sure we find the ovaries, maneuver the probe, use our Doppler, and in the end, make sure, if we don't have an answer, think beyond gynecologic conditions. Thank you for your attention.